plasminogen pathway.
This meeting is being recorded.
When you use SUPAR, you take the patient's blood in a quick test, real time. And if you detect any regional wall motion abnormalities perioperatively, especially while in ECMO patients or in aortic stenosis or off-pump CABGs, it's a very good marker to tell you at that time whether there is ongoing ischemia or not. A result within 2 minutes. So that's a great thing. Costing something like 2,800 per test, but for research it comes down to about 2,200. So we've got kits as well as you can do it ELISA-based as well as quick tests. Thank you, sir. Thank you.
Thank you. Thank you so much. Good morning, everyone. Welcome to the Sunday breakfast session dealing with echocardiography. Thank you for joining us. This is being done under the auspices of Forum of Cardiac Anaesthesiologists, which is IACTA Bangalore chapter, Indian College of Anaesthesiologists, Indian Association of Cardiothoracic Surgeons, and the Indian Society of Critical Care Medicine Bangalore chapter. Welcome to this edition, and we have two eminent faculty to discuss the management of mechanical circulatory devices, the utility of echocardiography in these patients, excepting the ECMO. ECMO will be dealt separately. So we'll be dealing with mechanical support devices other than ECMO today. And before I request Dr. Poonam Malhotra to take over, I request all of you to keep your mics in the mute mode and videos off. All the participants, except the speaker and the moderator, must have the mics muted and the audios off till the end of the talk. After the talk, you can unmute and speak if you want to. Please keep all your mics muted, very important. And then with this, you may please post your comments and questions on the chat box or unmute yourself after the talk and speak onto the microphone in your system. We'll address most of the questions as long as it is in the time frame of this meeting. We should be ending by 10 a.m. With this, I would like to invite Dr. Poonam Malhotra, who does not need any introduction. She is a professor of cardiac anesthesia in the All India Institute of Medical Sciences And we have Dr. Arupratan Maiti, who is a bright star in the horizon of cardiac anesthesia, trained in Rabindranath Tagore and UK, and currently in Kolkata. With this, I request Dr. Poonam to conduct the session. Thank you so much for joining.
Thank you, Dr. Mulidhar, for giving this opportunity. It's always a pleasure to join on the Sunday breakfast sessions. It begins the Sunday with a scintillating academic as well as, for me, a kind of a spiritual note too. And today we have a very good session coming up with Dr. Arupratan Maiti coming from Calcutta to tell us about a wonderful subject. Dr. Maiti is someone whom I've known and I can place, but he is a big man in Apollo Gleneagles Hospital today. Graduating and graduating from the Calcutta University, West Bengal, he went on to UK to do his fellowships and came back to work back in Calcutta, which is in itself a big thing of the patriotic nature of this bright cardiac star with us today. He'll be talking on echo assessment for left ventricular assist devices, for ECMO, and for all mechanical circulatory devices. So between me and him, I just want to say, with mechanical circulatory devices coming up in a big way to bridge the gap as to recovery, to transplant, as well as bridge to decision, we need to do echo as intensivists and also as anesthesiologists and surgeons in the OR. So right from the OR to the post-op, how to make a decision even in the pre-op, it is echo for us as the stethoscope of the well movement of mechanical circulatory devices. So over to Dr. Maiti to tell us more details about how to use them for what kind of devices. Welcome, Dr.
Thank you, ma'am. Thank you for your kind introduction. I'll try to share my screen. Sorry. Can you see my screen, ma'am? Can you see my screen? Hello?
Not yet. Can't see the screen. I can see your profile. I can see your profile.
Oh, sorry.
Share screen.
Now? Now?
Not
First
yet.
page?
No,
not yet.
Not yet.
Okay, just a second. I'll try to do it. I don't know what's happening.
Can you do the share button, Rajiv? Can you help him? Rajiv? I think, Dr. Maiti, you have two share screen buttons. No?
It's one share screen. Enter screen and what? No.
Yes, sir, your screen is visible. Can you open your presenter PPT? Yes.
Yeah, much better. Yeah, it's better. You just have to make it full screen. Perfect.
Is it full screen? Is full screen now?
Perfect. Yeah. Very
beautiful.
Very beautiful.
Yeah. Thank you. Thank you. So today I'll talk about the echocardiography for the mechanical circulatory devices, except ECMO. So I'll not waste much of the time. I've got no conflict of interest. These two articles have been very helpful for my to prepare my presentation, and I have taken a few images from them. And so basically, when I talk about the mechanical circulatory devices, I'll talk a bit about balloon pump and something about LVAD and temporary RVAD, impeller, and few lines about the total artificial heart. So straight away coming to the balloon pump. So balloon pump is commonly used worldwide and in our country. So this for this balloon pump, pre-balloon pump implanters and echocardiography wise, we need to see few things. Firstly, there is any gross atheroma. They are in the aorta, any part of the aorta descending across the aorta of the arch of the aorta, or we should grade the atheroma grade 4-5 atheroma may be dangerous when you insert the balloon pump because it can cause a stroke. And also something, if there is something in the aortic arch, that can also put some threat. So we have to be cautious before putting the balloon pump. And also the degree of AR, if there is any AR more than mild to moderate, that will get worse. So if the patient has more than mild AR, a balloon pump is a relative contraindication, but it's all relative nowadays. And coming to the IVP placement, so basically we need to see the descending mid-esophageal, descending thoracic, short axis and long axis view. The guide wire is passed through the femoral artery, and we can see the guide wire in the long axis and in the short axis, or alternately we can see by explain. And then we have to slightly withdraw the TOE probe until we get the left subclavian artery. So in descending thoracic long axis, we can see the where, and this is the balloon tip, and we can actually see the balloon in the descending thoracic aorta. Ideally, it should cover 80 to 90% of the descending thoracic aorta to have maximum effect, but many times it's not seen in echocardiography. And after the balloon pump has been placed, when we can see such kind of reverberation artifact, that means the balloon is in place. Instead, if in the aorta we see a lot of air bubbles, that means the balloon has ruptured. We need to stop the balloon immediately and take it out. So coming, oh, why? I missed two slides. I think well, there's some complications of balloon pump anyway. So coming to the LVAD. So left ventricular assist devices is quite common now as a bridge to transplant, as a destination therapy, or we can use LVAD as a temporary support to the left side of the heart. So basically, LVAD nowadays mostly the third generation LVADs are used, HeartMate 3 or hardware LVAD. This is the hardware LVAD HVAD 3. You can see the inflow cannula of the LVAD, and sorry, it's not working. And if you put color across the LVAD cannula, there will be a lot of magnetic aliasing of the color. We can see sometimes this happens, and obviously 3 will give you better delineation of the inflow cannula than the 2D, because it's a HVAD, so the cannula is small. In case of HeartMate 3 or HeartMate 2, the cannula is much more elongated, and we can see it much better. And so before putting the LVAD, it's very important that we assess the RV function of the patient, and which can also, we can also tell whether the patient may need a post-operative RVAD placement or not. So basically, we look at the RV fractional area change. Less than 20% predicts post-op RVAD placement. And if the RV free wall strain less than minus 14%, normally it's anything minus 25. If less than 14%, patient will have post-op RV dysfunction. And if the RV free wall strain is less than 9.6, then patient will probably need a RVAD. And this is also very important that RV to LV end-diastolic diameter ratio, anything more than 0.72 or 0.775 predicts post-op RV dysfunction. And the degree of tear may be blunted because when there is high right atrial pressure because of the heart failure. So after the LVAD has been placed, the grading of the tear may increase. And also before placing of the LVAD, we should always look at the PFO because it can cause hypoxemia when the LVAD is sucking too hard. And any clot in the heart in the left atrial appendage should be carefully evaluated because it can cause pump thrombosis and systemic embolization. That's why I always image the left atrial ostium, left atrial appendage ostium by 3D to make sure there is no clot there. Is the best way to do it. Also, you can put an X-plane. So any clot in the LV anywhere is a contraindication. So far, is a contraindication to a LVAD. but sometimes nowadays it has been relative contraindications because the surgeons will take out the clot and put a LVAD through the apex. And infective endocarditis is absolute no-no for LVAD. It's absolute contraindication for the LVAD. And the degree of AR again is very important. So the degree of AR again may be underestimated because the heart is failing. The patient has got high left ventricular end diastolic pressure. So the estimation of the AR will definitely be lower than what it will be after the LVAD replacement. So that's why it's very, very vital that we carefully look at the aortic valve and we assess the AR. If needed, we need to repair the aortic valve. Any aortic pathology like aortic dissection or gross aortic aneurysm, LVAD is contraindication. So other valvular lesions like MRAs, MSPR, that should be seen, but obviously we have to be careful. We have to be careful looking at all the valves because particularly severe MS should be addressed. And the assessment of the LVAD, small LV cavities, and if there are too many trabeculations, then LV apical aneurysm, then LVAD will become a problem later on. Sometimes the thrombus is laminated in the apex and is difficult to diagnose, and that thrombus can be migrated into the LVAD, causing pump thrombosis. So post-operatively, first thing, very important thing is to make sure adequate de-wearing has been there. Adequate de-wearing is very important. Otherwise, patient will have embolism. A lot of wear can be there. And sometimes the PFO can be unmasked, causing a right to left shunting, causing hypoxemia. And now coming how to optimize the LVAD speed by echocardiography. Basically what I see, I look at the septum. I look at the septum and the septum should be in midline. And I see, and I want some septal bounce, as in this case, some septal bounce is needed because septal bounce is responsible for 1/3 of the RV cardiac output. So septum should be in midline and there should be some septal bounce. This cannula should be in the mid of the LV towards the mitral valve, not towards the septum and not towards any other wall. And then we'll put color across the mitral valve and hopefully the mitral regurgitation has gone down and patient has reasonable mean blood pressure. That's how I optimize the LVAD speed. So septum in midline, some septal bounce, cannula position in the midline, MR and AR and TR has gone down, reasonable RV function, and good hemodynamic parameters in the form of good flow. That's what I need. And at the same time, I want some aortic valve opening, which should be intermittent. Otherwise, there should be clot in the aortic root. So RV dysfunction is quite common after LVAD implantation that we should detect quickly. You can see that the septum has bowed towards the left and RV is quite big in this case. In this case, is this playing or not? It's not playing well. In this case, the RV is still dysfunctional, but still it's not working. Sorry, some longitudinal function was there, but the free wall function was absent. But the RV is at least small, not very dilated, and septum is in midline, so it's kind of acceptable. So in this case, the aortic valve is not opening at all. So ideally, the aortic valve should open intermittently. In this case, it's not opening at all. So this patient has got chance to have formation of thrombus inside the LV cavity or somewhere in the aortic root. Rather, I can see the complication. So the A is the big thrombus sitting in the aortic root because the aortic valve was not opening sufficiently. In this case, the aortic valve opening in each heartbeat, which is not also ideal. And basically, we want intermittent aortic opening. The beat is just jerky. I don't know why. So pump speed optimization I have already discussed. We need to look at the inflow cannula. This is the HeartMate 2 hardware I've taken from AAC journal. And as I told, the HeartMate 2 LVAT are very easy to see because they are kind of elongated. And inflow cannula speed should be 1 to 2 meters per second. We can put a color Doppler across the inflow cannula, and the velocity should be 1 to 2 meters per second. And anything more than 1.5, we have to be cautious to look for the causes why the velocity is high. And the outflow cannula is similarly, the velocity is anything between 1 to 2 meters per second. As you can see, the flow across the outflow cannula, and this is flow across the outflow cannula again, and you can see a CWD across the outflow cannula and take the velocity. It should be again less than 1 meter per second. Anything more than 1.5 is significant. We need to look for why the causes, why the velocity is high. And obviously, LVAD can cause a lot of complications like gross pericardial effusion and causing tamponading, reducing the LVAD flow. Sometimes, if the patient is hypovolemic and the LVAD speed is very high, the RPM is very high, the LV can be sucked down, as in this case, and after giving volume, restoration of the LV cavity and flow. And the LV thrombus can happen over the time period. Basically, what we do, we need to put a mode across the aortic valve opening. So initially, when you insert the LVAD, the aortic valve opening is very small, the duration, like 107 seconds in this case. But as there is thrombus in the LVAD, you can see the box here, rectangular box, the duration of the aortic valve opening will be prolonged. So that is one early sign that there's a thrombus being formed in the LVAD. We need to escalate the anticoagulants. So LVAD inflow cannula again can be malpositioned. As I said, that the cannula should be in the midline facing the mitral valve. In this case, it is aligning, it's hinging with the left ventricular wall. Obviously, the LVAD flow has dropped down significantly in this case, and the power has gone up. And so when LVAD, the video is not running, when the LVAD has caused significant RV dysfunction, RV is not decompressed, it's time that we put a RVAD. So RVAD can be through central cannulation with a RA and PA, and also can be later on by peripheral cannulation. You can also put the pulse wave Doppler to see the flow across the RVAD. And this is something called Impella RP, which is a temporary RVAD support. It's like an impeller. It's a right-sided impeller. So you can see the this A is the impeller RP. You can see in the pulmonary artery. And if you put color here, you can see the mosaic pattern here. And interestingly, you can see the B is the impeller 5 in this case. So the patient has got both left-sided impeller 5 and right-sided impeller RP. So basically, for impeller RP, echocardiography can guide for its location, and this makes sure that the impeller is properly positioned in the right pulmonary artery. Ideally, it should be in the right pulmonary artery, in the pulmonary artery towards the right, so that you can also put a PA catheter. And this is impeller 5. And another cannula called Protect Duo cannula, by which we can also put a transcutaneous RVAD. So the Protect Duo cannula basically is a very large cannula, 29 French cannula, and which you put through the internal jugular vein. And the inflow inlet stays in the RA, and the outlet stays in the pulmonary artery. And it works as a percutaneous RVAD. So this is the Protect Duo cannula. You can see the cannula Protect Duo. This is the inlet seen in the right atrium. And we can see also the part of the Protect Duo traversing the RVOT here, going to the pulmonary artery. And the Protect Duo cannula this is the cannula you can see here, and it can sometimes cause significant tear. Then sometimes we need to reposition by the Protect Duo cannula by echocardiography guidance. And coming to the Impella 5, I think this is the most popular device now coming up. And Impella is a temporary LVAD. And it has got different types of Impella: Impella 2.5, Impella CP, Impella 5, and now come Impella 5.5. So Impella 5 means it gives cardiac output of 5 liter. So Impella is usually inserted through a femoral artery or axillary artery. So basically, echocardiography guidance is very vital. Sometimes they put under fluoroscopy, but I think echo is more helpful than fluoroscopy. So basically, we can guide the guide wire, where the guide wire is going from descending thoracic aorta to the crossing the aortic valve into the LV. As you can see, the Impella has crossed past the aortic valve and come to the LV. And in the long axis view, I think this view should be kept when we're doing live. This is the Impella, the part of the Impella. This is the inflow inlet is traversing into the going into the LV, and this is the outlet. They are fairly away from the aortic valve, but still it's in the aortic sinus. So ideally, it should be beyond the aortic sinus. And the distance from the aortic valve to the inlet of the Impella 5, that should be around 3.5 to 4 centimeters. Otherwise, if we put it too much inside, then it can avoid the left ventricular apex or left ventricular wall, and it will not do well. And sometimes what happens, and you can also see the color flow across the Impella, and some mosaic patterns should be observed at the outlet. So this is the inflow. You can see here some color, and this is the outflow of the Impella. Sometimes what happens, the Impella gets migrated. So both the inflow and outflow gets into the LV. In that case, there will be significant recirculation, and obviously hemodynamically patient will be unstable. And that's why echocardiography is so important for Impella. And also, you can, if you have a good 3D, you can see the Impella traversing from the aorta, aortic sinus, and going into the LV. And in this case, this Impella causes significant damage to the mitral valve and subvalvular apparatus, causing MR. That's why we have to make sure that Impella has reached this desired distance not too far. In this case, the Impella has almost reaching the mitral valve and cause complications. So better, the Impella direction should be towards the apex, not towards the mitral valve in this case. So coming a bit of the tandem heart, basically tandem heart is again a temporary device, and it's kind of temporary LVAD. It's a centrifugal pump. For that, we need a cannula in the ALA, one cannula in the femoral artery. So through the femoral vein, the guide wire is passed, and it causes some, and we need a transseptal puncture, atrial septal puncture. So basically, first we need a tenting at the mid of the atrial septum, then the guide wire crosses after puncturing the interatrial septum, and then the device goes into the LA. And the blood from the LA then will be drawn through the and will be pumped with a centrifugal machine in the femoral artery. So in the femoral artery also, we need to check the guide wire by echocardiography, and we need to put a cannula in the femoral artery. And the tandem heart can give a maximum cardiac output of 4.5 liters. So in LA, it makes sure that we have to make sure that when you were puncturing, there is a tenting and the cannula is in right position. So this is the fenestrated cannula of the tandem heart. You can see the cannula in well position. And in this case, if you see a color flow, the pulmonary venous flow is going into the LA, and is then tandem heart is sucking that flow from the LA. And something about the total artificial heart. I have no experience of this total artificial heart, neither I have used them. So the SynCardia is FDA approved since for some time, for a few years now. So basically, they put a heart in the ventricular space, and they will have two valves. In the A valve is the mitral valve of the total artificial valve. These are all Medtronic Hall valves, and B will be in the tricuspid valve in the tricuspid position. I should not say like mitral valve or tricuspid valve, rather I should say valve in mitral position and valve in tricuspid position. So basically, we can also see in the 3D that the nice position of the valve in the mitral location and valve in the tricuspid location. These are all single tilted valves. So opening and closing can be seen accordingly like single tilting disc valve. And echocardiography wise, before inserting the total artificial heart, we have to make sure by echocardiography that the CVP catheter is not coming towards the right to the tricuspid valve. Because if this right catheter, the CVP catheter in the is coming to the tricuspid valve, it will cause significant dysfunction of the Medtronic tricuspid valve when they put them, and so that should be withdrawn accordingly. And also we need to see, very importantly, in total artificial heart, the pulmonary venous flow. We need to show that pulmonary venous flow is normal, so that total artificial heart can work normally, and also the flow in the inferior vena cava. So these are the 2-3 things which are important in total artificial heart, which is the echocardiographic findings. What we look for is slightly different in total artificial heart than the other devices. So I think that's all what I have. Thank you, but I'll be happy to do some discussion.
Thanks a lot, Dr. Maiti. I think that was a very wonderful, very detailed, yet very crisp and to the point discussion on echo for LVADs. And IABP, you showed some very significant point about the guide wire placement for IABP, which is so very important, because most of the time, how do you see it in the upper aortic short axis view, how you see it in the descending thoracic aorta, all these pertinent points make it very obvious that we need IABP to be guided by an echocardiographer for the surgeon to put it, A, place it well, B, see the aorta that it doesn't cross into and puncture beyond the left subclavian. You showed the short axis as well as the descending thoracic aorta long axis very well. Something else that you talked about, and I want to ask you about it, you showed very beautiful pictures about the pump speed optimization on an LVAD. You were showing the hardware and how the pump speed optimization can be done with the hardware. I want you to just tell us a few details. When you were an echocardiographer, what would be the best, the view? Like I say, for aortic valve opening, I would look into a mid-esophageal long axis view, and I would want to see the optimized aortic valve opening. It should not be with every heartbeat. You showed it very beautifully. It should not open, but it should intermittently keep opening, so that LV distension that we are seeing is well taken care of. But how do you discuss the views for speed optimization? What 2 best views would you think of when you put a hardware for LVAD hardware speed optimization?
Yeah. So basically, there are 2 views. Most important is the mid-esophageal 4-chamber view, because the mid-esophageal 4-chamber view not only gives me about the LV, but also gives me about the RV. So during speed optimization, it's essential that I get a significant, good number LVAD flow with a good mean blood pressure, some ejections. At the same time, I should not allow the pump to run too hard that our RV will be sucked in, or RV dysfunction will ensue. So that's why it's very important that when I'm optimizing the LVAD speed, the RV is reasonable. Obviously, with each and every LVAD placement, there will be some degree of RV dysfunction. There has to be, but how much I can accept. That's why what I do, as I said, I keep the interventricular septum in the midline. That's my first point. And second point is that I will take a septal bounce. That's very important to me, because septal bounce causes 1/3 of the RV cardiac output. If the septal bounce is lost, that means either the LV is very much stressed, it's not decompressed, then probably we need to increase the LVAD RPM. And obviously, with increasing the RPM, if the patient had MR prior to the LVAD implantation, the MR should come down. If there is at least moderate AR after the LVAD implantation, then the lungs will be flooded. And eventually the RV will be dysfunctional later on because of the bad lungs. So mid-esophageal 4-chamber view not only gives me the optimization of the septum position, but also the RV, which I look for. Also, I see the tricuspid regurgitation, how much it is, because pre-LVAD implantation, always the right atrial pressure will be high, and it will mask the tricuspid regurgitation. As the LVAD is initiated, the RP will low. Straight away, RP will be low, and then tricuspid regurgitation may be unmasked. That's why preoperatively we should measure the tricuspid annulus and to report to the surgeon if it's more than 43 centimeter or just index is more than 1. And next view is the mid-esophageal 2-chamber view, because the apex of the LV is best seen in the 2-chamber view. And for the LVAD inflow cannula placement, it's very important that I see the apex of the LV not foreshortened, and neither it's in the midline towards the mitral valve, and neither going towards the septum, not towards the lateral wall. And sometimes what happens in nowadays, we are also putting LVAD in HOCM patients. The LVAD is the ventricular cavity is very small. The lot of trabeculations that can really cause problems. Sometimes we've seen the trabeculations has reduced the LVAD flow, and we had to cut a lot of trabeculations and muscles in the LV, then put the LVAD, they reposition the LVAD inflow cannula. And then when I'm happy in 4-chamber view and 2-chamber view, then obviously intermittent opening of the aortic valve can also be translated in the monitor by the ejection in the arterial line. But still, I'll still see in the mid-esophageal long axis view and put a M mode also, will take the distance with the duration of the aortic valve opening. So the duration should be somewhere 100, 150 is all right for me.
Okay. Now, while you're talking on LVAD, we do a lot of echo for ECMO. And when we do echo for ECMO, we look at trabeculations in the RA, a Chiari network. Just as you mentioned, PFOs, the ASCs may harm the cannula position, cause migratory cannulas to go from the RA into the LA and create a right to left shunt. You also mentioned the same there. Now, in ECMO, which could be VV or VA, particularly in VA ECMO, we see the RA trabeculations. We rule out any obstructing sites in the RA, the opening of the SVC into the RA, the opening of the IVC into the RA, and putting maybe a dual chamber cannula or a single stage cannula into the mid cavity of the RA. Now, while we are doing this, it's also important to know not just the migration and the malposition, but also the casts around the cannula. So how do you detect the casts around the cannula on echo is one question while you're on ECMO. And second question is from Dr. Kirti Chandran. What all echo parameters to monitor during the ramp test in LVAD? So two questions to you. How do you visualize the venous casts and the thrombi on cannulas, near the cannulas in an RA or across an LV? You showed beautiful pictures of inflow cannulas, LVAD. You showed a video on that in the LVAD. But how would you look at the echogenicity? Would it be hyperechoic? That's what I want to know. How do you detect that these are casts?
Okay, so the first question, if I'm not wrong, how do I detect the echogenicity and thrombus around the cannula?
Yes. What all would you look at on the echo? The echogenicity, the diameters, the change in pattern, whatever on the cannula.
So basically, if there is any thrombus in any of the cannula, be on ECMO or be on LVAD, so obviously you can see obvious thrombus. You can see obvious thrombus at the mouth of the cannula or also elsewhere in the heart. Sometimes I've seen heart full of clots. Obviously, cannula will be clotted. And second thing is that if you put color, then there will be turbulent flow. The flow will not be laminar. Then there will be turbulent flow. And if I have good aligning with the Doppler and put the CWD across that, obviously the velocity in that will be very high. And not the least, that if any says inflow or outflow, inflow is not draining, then the chamber will itself dilate. The chamber will be distended and dilated. And the regurgitant lesion, like in case of the RA cannula, the regurgitant lesion like tear will increase. You will straight away see the RV is dilated, the tear has gone up, and there may be some query or some thrombus in the cannula, and the flow velocity has gone up, the flow is all turbulent. And patient is hemodynamic. Obviously, we have to see the patient's hemodynamic monitor at the same time the hemodynamic has deteriorated. So just an echo finding, echo can give a lot of finding, but it should always be correlated with the clinical parameters. Why you are doing the echo and what you're looking for. And the second question is about the RAM protocol. So the RAM protocol, absolutely different protocols across different institutions. Basically, we see the left ventricular end diastolic diameter. The RAM protocol can be done for the LVAD, for the ECMO, for any devices. So basically, we gradually increase the RPM of LVAD, and we see how much flow we are getting through the LVAD, and we see few echocardiography parameters like L ventricular end diastolic diameter, whether LV is getting decompressed, whether MR is coming down, whether TR is coming down, and how much RV dysfunction it's causing. So those things we see in RAM protocol. It's not a fixed protocol. It differs from institute to institute. Basically, we all do by RAM test only. We don't straight away start the VAD to 4,000 RPM or something in AVAD or 8,000 in HeartMate 3. So it's gradually increased by 1,000 increment at a time, and you see the echo, see the arterial monitor, see the aortic valve opening, and then increase further. And once we just optimize, or we think we are optimized, then we stop that. Yeah.
Hello.
Is it big?
Hello, good morning, sir.
Yeah, good morning.
Yes, carry on.
Yes, sir, can I ask one more question?
Yes, yeah.
Sure.
Sir, in cases of LVAD, where the only LVAD is placed, most of the parameters to assess the right ventricle after surgery, they won't be reliable. How do you assess the right ventricle? Because most important is to assess the right ventricular function. So apart from all the parameters, which are the reliable according to you to assess the right ventricular function post LVAD syndrome?
Fractional area change. FSC is the most not only, I'm coming to that. FSC is the most robust parameters post cardiotomy, because TAPC is not valid after cardiotomy. So because of the pericardial constraints are gone, TAPC is not valid. So FSC is a very good parameter for assessing RVAD function post bypass, post LVAD implantation. Also, you can see the S prime, the annular tricuspid annular velocity, and if you have a strain, RV strain, you can use them. But immediately post-op, because of too many things, I will use the fractional area change. If that is less than 20% after this LVAD implantation, then be cautious. I just said all the patients with LVAD implantation will have some degree of RV dysfunction. Some may have mild, some moderate or severe. Go for FAC, and FAC is very easy to see, and later on it can be followed up very easily.
Dr. Maiti, very often we see that the pulmonary artery systolic pressures on the right side, especially let's say on ECMO, just at the initiation of ECMO or initiation of LVAD, they are down, right? And suddenly when ECMO starts within 48 to 72 hours, you see this improvement in pulmonary artery systolic pressures, you see improvement in time to peak velocities, and velocities across the tricuspid valve very nicely at that time tell us more about the RV function than, let's say, an aortic velocity at that time or an aortic VTI for the LV function. So RV function, I personally feel at the initiation, the pulmonary artery systolic pressure, the time to peak and the peak systolic velocities across the tricuspid play a very important role, along with, as you rightly mentioned, the fractional area change and the TAPSE. MO TAPSE is probably a very, very good marker for more than 1.5 or less than 1.5 at that time for the systolic excursion. I personally look at it, but what is your opinion for the velocities of the right side? And as Dr. Muralidhar was asking you about the strain on the right side, the RA strain and the RV strain, because most machines are not optimized.
Yeah. So basically there are a few clinical parameters and numbers and the echocardiographic numbers. So clinical numbers is something called the pulmonary artery pulsatility index, PAPI, which is basically the systolic pulmonary artery pressure minus diastolic pulmonary artery pressure divided by RAP. That should be more than 9 normally. If that is less than 9, that means we have got some degree of RV dysfunction after LVAD. This is particularly parameter has been described after LVAD implantation. And regarding the numbers, FAC normally is more than 35%, less than 20% is significant, because that time you need something. You need something to help the RV, and particularly the strain gives more idea whether the patient will need RVAD later on. If the right ventricular strain, longitudinal strain, is less than -10 or -9.6, then patient will probably need a RVAD after the LVAD implantation. If not now, but after some time in the ITU, patient will need the RVAD implantation. And if you can see the S prime, the number is more than 6.6, less than 6.6 centimeter per second. That means the RV is really bad. And less than 4.4, that means it needs something, mechanical devices.
But S prime is a very good marker on tissue Doppler velocities because it tells us, it alleviates the loading conditions of any loading conditions in the ICU particularly. But at the same time, most machines today are geared up for 3D quantifications, yes, for 4D also, yes. But for tissue Doppler, there is a difference in the machine softwares, and some are very good, some are not so good. What to do when you don't have not so good things? You can't get an S prime, which is too accurate. You can't get a GLS -9 or -4, as you mentioned the numbers. What would be your best parameters in those machines which are not so good?
So basically, it's a trade. It's a trade when coming off LVAD. It's a trade whether we give something mechanical to RV or not. So basically, we see the. I'm very fond of the septal bounce. The septal bounce is there. That means I've given 1/3 of the RV cardiac output. I see the usually longitudinal function is usually lost after LVAD placement. Usually it's the free wall which is contracting and contributing to the RV function. If there is some free wall movement is there, and if the RV small is not dilated and the tear is not grossly, it's a gross tear, I accept that RV function with reasonable inotrope. And then whatever be the numbers, if the FAC comes like 20-25%, I will accept that.
You mentioned while we are on the right side, pulmonary venous flow pattern. This is normal or not? In the tandem heart you were mentioning.
Yes, that's right.
What importance you give to that? Because we at our center give a lot of importance to TAPSE, FAC, the PASP, and the pulmonary venous flow. So could you explain that? How would you do the pulmonary venous flow calculations to so many of them who join? How would you optimize it to say it's normal or abnormal?
So basically,
any MCS.
Yeah, basically, I mean, I don't measure the pulmonary venous flow, but what I see put the color across the pulmonary veins. These should be laminar. Firstly, it should be laminar, and it should be the velocity should be there. The velocity should not cross more than 1 meter per second. So after tandem heart, implantation or after total artificial heart, if the velocity, or even after heart transplant, if the velocity has gone up more than 1 meter per second, and if the it has become turbulent, not laminar, not a rate flow, it's a alizing flow, then definitely something wrong with the pulmonary vein. So I need to probably reposition the cannula. And sometimes as a tandem heart, it's also very important that we check for any clots in the left atrial appendage very, very cautiously. That's why 3D imaging of the left atrial appendage opening is very important in tandem heart.
Yeah, many of them may be wanting your talk. Are you okay with it? They're asking for the talk to be repeated, so they want the talk. Some people have written to me recently just now. And lastly, before we end, Dr. Maiti, on a very beautiful talk that we've had, one last question to me. If I was to initiate an ECMO or a MCS, what 5 best parameters biventrically would you see? What would you advise to our novice echocardiographers or expert echocardiographers, that what would be the 5 best parameters to view? You could think that we are on an advanced machine and you want to, in 10 minutes, tell them whether you need an Impella 5 or not. We still don't have Impella in all centers, whether it's 2.5 or RP or 5, and we still are putting hardwares or a BiVAD, and we are all waiting for, more and more of centrifugal pumps. But if you know what is happening at the ECMO, post the Russia war with Ukraine, with the silicon chips not available, there is a recall on the oxygenators by ELSO for even the Meke Quadrox oxygenator. So when we're going to see a shortage, and the shortage of LPADs is going to be there, shortage of ECMO is going to be there, we hope it's not there, but a recall also means more research. But if you were to put a very expensive item like an LVAD there in a patient, what 5 echo parameters would you best say optimize an LVAD placement or an ECMO placement? To your mindset, with your experience, the 5 best parameters. Dr. Maiti? I think it's, the connection has gone, sir. Is that right? Dr. Mulidhar?
I'm not sure. Dr. Maiti, are you there? Dr. Maiti?
I think suddenly the connection has gone, or his recording has ended. But it was a very beautiful lecture. I think there are no more questions on that end.
It was a lovely talk.
Yeah, it's a very nice, and your screen sharing, I think everyone's screen sharing was there. So no more questions. But if I was to summarize the 5 best parameters, I would put a lot of emphasis on ejection fraction, fractional area change, both on the LV as well as the RV. I would want to look at my velocities across the aortic valve, the mitral valve, as well as the tricuspid valve. On the right side, see the pulmonary artery systolic pressures and the diastolic pressures, or a mean pulmonary artery pressure with the TAPSE also on the right side. And on the left side, I would like to look at the aortic valve opening along with the VTI of the aortic valve, and rule out an MR if it is worsening or it is getting better if it was there. So these are some 4, 5, and he mentioned a very beautiful parameter, S prime, and he spoke on of the S prime as one of the best parameters for all kinds of LVADs or RVADs. So those would be the 5 good things to say with their numbers that we need MCS in our patient. Dr. Mulidhar, would you like to round it off?
Thank you. Yeah. Thank you so much. Cardiography in mechanical circulatory device, accepting ECMO. All the most common devices have been mentioned: IABP, LVAD, Impella, right-sided Impella, tandem heart, Protect Duo, and I think all the devices have been mentioned in a brief but succinct manner. All the important points were mentioned. And I would like to thank you, all of you, for joining us. And special thank you, Dr. Poonam Malhotra and Arupratan, for the excellent session. Thank you so much. We'll meet you again next Sunday. Thank you so much.
I got disconnected.
Yeah, I thought so. I thought so.
But your talk was excellent.
Thank you so
Dr.
much.
Maiti. Thank you.
Thank you, ma'am.
Thank
Thank you, ma'am.
Excellent.
So
We'll talk
people
later.
want you to repeat again. So after a couple of months, we'll ask you to do the same thing.
No problem. So maybe I can do a more elaborate
Thank
talk
you.
because I finished, I think, 10 minutes prior to my scheduled timing. So yes, I can do something.
That's good. We got a lot of time for discussion. Thank you so much.
Thank you. Thank you.
Excellent. Thank you.
We'll
Thank
see
you,
you
Dr.
sometime
Maiti.
later.
Thank you.
Thank you.
Thanks, Dr. Maiti. Thank you, Rajiv.
Thank you, ma'am. Thanks.
Thank you, ma'am.